my eminent colleague, Dr. Bilur, plastic surgeon from Istanbul, Turkey. And today we have a beautiful model. Thank you, Dr. Patrick, for the outstanding anatomical what we see now, the anatomy on a cadaver. So I will join it, but clinically on the patient, as we see here, can we have a zoom in, please? As we see here, to recap, so we have the facial artery, which is the main blood supply of the face, which arises in the face in front of the masseter, goes in a tortuous pathway, then it gives us the inferior labial, superior labial, and then it goes all along in the nasolabial fold, or in some cases lateral to it, and continue to give us the lateral nasal branch. Then it continues the lateral wall of the nose. Then it continues as an angular artery and give us also a branch which is called the dorsal nasal artery. Here we have the facial vein just in front of the masseter, continue in the nasojugal groove and continue in the tear trough. It's superficial, and the facial artery just under the E to E safety line, which extends from the tragus of the ear till the mouth corner. It's deep on the bone, so we inject under the safety line superficial to avoid any danger. And one of main branches of the facial artery is the submental artery, and it gives us the ascending mental lateral to the midline. Usually it's in the muscle here, and it can be superficial also in 30% of the cases. We have a main supply from the main branch from the external carotid artery, which is a superficial temporal artery, and it goes all along in the lateral side of the face till it reaches the temples, and it gives us the parietal branch and the frontal branch. And the danger here, because it anastomoses with the supraorbital artery. Under the lower border of the zygomatic arch, here we have the transverse facial artery, which can anastomose with the infraorbital tributaries in the vascular bundle. 25 millimeter from the lateral canthus, here we can have a small foramina called the zygomaticofacial foramen, which the zygomaticofacial vessels can arise from the zygomaticofacial artery can arise from here. Regarding the muscle here in the lower face, we have the masseter muscle. The masseter muscle is a muscle of mastication, and it's covered also by the platysma. The platysma is continuation of the SMAS in the mid face and the gallia in the upper face, and it goes all the way to the neck. Then here we have the DAO, which is a triangular muscle, as Dr. Patrick explained to us. Then we finish the vascular supply. Now we are going into more of surface topographical anatomy. So we will inject in Yulia, which is 42 years old. She's healthy and well. She asks for, like, as we say, more healthier, more rejuvenated look. So we decided to inject her using RHA4 resilient dynamic fillers, multi-layering technique, deep and superficial. We have two fat compartments, the deep and the superficial fat compartment. Deep one in the cheek or the mid-face area, we can know it by drawing a line from the tear trough, continue in the nasojugal groove, one lateral line from the lateral orbital limb, vertical line, and the zygomaticus major muscle, which extend from the zygomatic arch till the mouth corner. And this is the boundary of our deep fat compartments. And medial to the vertical line, here we have the medial sousp, and lateral to it, we have the lateral sousp, and the intersection between the three lines is the deep medial cheek fat pad. And those fat compartments we are targeting. And if we see the surface coefficient volume, the most receptive fat compartment is the medial sousp. That's why when we inject the medial sousp, we will have improvement also on the tear trough area. And we need more volume in the DMC, or the deep medial cheek fat compartment, as we see this more and more deflated in the deep and lipodystrophic patients. We have to know that all deep fat compartments deflate due to aging. And also, after the deep fat compartments, we have the superficial fat compartment, which is, as Dr. Patrick discussed, we have the infraorbital, and we have the middle and medial and middle cheek fat pads, and we have the nasolabial fat compartment, which is a no-go area for us because in Yulia it's heavy and it's pretty full. Now we are injecting. We are following the Tuxan approach with the ATP. So we discussed the A, and aging It happens in all the layers. So as we said, we have deflation, all the deep fat compartments and in superficial fat compartment, except in two compartments. In the nasolabial fat compartment, which increase with age, and the jaw fat compartment. So we will spare these areas for injection. I would like to use the term reflate, because when we have a deflation, I will reflate it using the dermal fillers. Technique, we will show it now, and we will discuss also the P in the ATP approach, which stands for the products. We have to choose the right product for the right layer to achieve natural, outstanding result and respect the dynamic state of the face. So we are going to use today the RH4 because she has a thin skin and she needs a curvy look, not too much projection. That's why I will use the RH4 multi-layering in deep fat compartments and also in the superficial fat compartment, as it has stretch, strength properties, and we can use it as a resilient filler and a superficial volumizer. Now we are going to start the injection. Any questions, Balur?
Shadi, I would like to ask, when you are injecting, what is your general approach? Do you inject first the mid-face? Is that your preferred area to start off with? Or how do you go ahead to decide which area you're going to inject first in a patient when you're assessing?
Okay, after assessment, we have to start the assessment first from upper, mid, and lower face. Then we discuss, after assessment of the patient and aesthetic needs of the patient, we discuss with her that we need to inject the mid face first. Not in all cases, but if I will do a full face treatment, I will start upward, downward. So I will start with forehead or the upper face, then mid face, then the lower face, because I think mid face is it has a main impact on lifting of the lower face. So if we started with the mid face, it will improve the result and give us lower volume to inject in the lower face.
Yes, I totally agree with you. Absolutely.
Yeah.
So we can continue right now with your injection. That's fine.
Yes, thank you. So first of all, can we have the zoom in camera, please? We will mark, excuse me, zoom in, please. Yes, thank you. As we said, I will mark the inferior border, inferior orbital rim. Then I will see my fat compartments. I like to do the markings. So here the medial SOOF, here the lateral SOOF, and here the DMC. I'm starting using RH4. I'm using cannula, 25 millimeter, 25 gauge needle. Rigid
How long
cannula.
is your cannula?
It's 38 millimeter. It's almost 4 centimeters. So I will, it's 40 millimeters. So I will go deep till I touch the bone. And this is my entry point. I prime my cannula. When I'm targeting the deep fat compartments, I like to have the bevel down of the cannula. Down, I enter. All the way, as we see, gently, deep, and I can feel the resistance of the zygomaticocutaneous ligament. And I will go lift the tissues and advance my cannula through the fat compartments. How I know I'm deep? When I raise my cannula, I can see the tip of my cannula. I will inject approximately 0.2 milliliters in each fat compartment. I have a slow injection. I'm a slow injector, and I am all the way deep on the bone. I'm injecting and moving the tip of my cannula all the time to avoid any big bolus.
Are there any particular anatomical caution areas that you are taking care to avoid when you are doing this injection, Shadi?
When I'm deep on the bone here, I have to take care of the infraorbital foramina, which is 0.8 to 1 centimeter from the lower orbital rim, but it's more medially in the medial pupillary line. in the medial
Are you
limbus.
crossing the mid-pupillary line right now? Are you when you are injecting?
Excuse me, Blue?
Are you crossing the mid-pupillary line? Are you going
No,
medial to the mid-pupillary line when you were
no,
injecting?
because I'm injecting the medial suit, which extended from the mid-pupillary line till the lateral canthus.
Mhm.
So I'm not crossing it. Then now I will inject a little bit in the lateral suit. I don't want to lateralize her face, so I will inject a bolus. As you see, I'm keep moving, and I do micro aliquots just to improve. Then I press to massage it a little bit. Here, the properties of the RHA4, that it has a stretch and strength properties. So if we can see superficially any lumps, it's forgivable product and we can massage it easily. It's easily massaged. Now I'm going to target the D-fat compartment, the third one, the DMC, which will require the largest volume of the mid-face D-fat compartment. I'm raising the tissues to reach it. I'm deep on the bone, and then I'm using my dominant hand to guard. Then I'm inject while moving.
And how much have you injected in each compartment, Shadi?
I'm injecting 0.2 because she has a fair good volume, and then I'm out. So till now, if we can check the volume I injected,
We can zoom in.
it's 0.6.
All right.
So it's half syringe of RH4. And here's what I love about Yuxan. We don't promote injecting too large volumes. We just want to use the right product on the right anatomical layer according to anatomical knowledge to have safe and natural results.
Absolutely.
Now I'm using just so it goes just to improve the appearance and to massage it a little bit. Now I'm using the same fillers, and here's the properties of the RHA4. As I said, it can be used as lifting deep on the deep fat compartment, the static fat compartment, and it can be used superficially as a superficial volumizer in the superficial fat compartment, which will also respect the dynamics of the face.
Can I also ask, Shadi, we have a question. Is your injection technique a retrograde injection or is it anterograde, or are you giving small boluses?
I'm giving small aliquots, and
Mhm.
in the deep fat compartment, I want to fill the compartment. As we all know, the fat compartments are well compartmentalized. Then when we inject it, there is a septa between the compartments. I inject micro aliquots to fill it. And when I'm injecting in the superficial fat compartment, as we can see here, I'm in the subcutaneous superficial fat. I can see the level of my cannula. I can see it easily. And I'm injecting fanning retrograde line. Okay. Which are the fat compartments I'm targeting here? I'm targeting the medial and the middle, the superior middle part. So I'm injecting just retrograde lines.
And again, you're very slow, you're very controlled. We can see that.
Yes, I don't like to rush in my injections because the slower you are, the safer you are.
Absolutely.
And I will not inject too much.
Avoiding any particular compartments when you are injecting the superficial area?
Yes, I'm out of the inferior infraorbital fat compartment, and I'm targeting, and I'm out of infraorbital fat compartment and from the nasolabial fat compartment, which will inflate during aging. So I will not add any more volume. I'm just targeting now the middle and medial, and not all the middle, because the middle fat compartments of the superficial fat compartments in the mid face can enhance the jowling and it participate in the descent of the jowls. So I'm injecting only the superior part of it. I'm not crossing the cheeks because my line, the zygomatic major line, as we can see here, I'm injecting almost 0.2 superficially. I can go a little bit more.
We can see just, as you inject, how it's creating a beautiful curvature on the cheek. So it's looking amazing.
Exactly. So we inject just small amounts to enhance her feminine beauty, with respect of the dimensions and the proportions, because as we all know, now we'll set the patient. I inject in total superficially, we can say 0.3. So I still have 0.3 left.
Could you also tell us how you picked your entry point, Shadi, one more time, because our listeners, our viewers wanted to know how you picked the precise point of entry for your cannula.
Okay, if we can see here, can we sit, please? Zoom out. Okay, as we can see here, I have 3 lines. I have, as we said, the mid-cheek groove, lateral vertical line from the lateral canthus, lateral orbital rim, and then we have the zygomaticus major muscle, which is the boundary of our deep fat compartment. Medial to this line, to the lateral line or the vertical line, we have the medial SOOF, and I stop at the nasojugal groove. Lateral to it is the lateral SOOF, and the intersection between the 3 lines is the deep medial cheek fat pad. So when I want to know where to enter, I have to just use my cannula to understand the length that I want to reach. So my entry point, I prefer the lateral one, and I'm reaching the medial SOOF. Then I go a little bit to inject on the lateral SOOF, all deep on the bone in the deep fat compartment. Then I move my cannula here to inject the deep medial cheek fat pad. So I prefer the lateral one. I don't want to go from the lower to avoid any danger here for the facial vein, because we don't want any hematomas or bleedings.
Okay. And you used the RHA4 product, and you mentioned how versatile it is both for the deep and also for the superficial compartments. But of course, there are other combinations that we could also utilize. For example, we can use the ultra deep, which is a very good stiff volumizer for the deep fat pads.
Exactly.
Can you mention a little bit about how you choose which product to use for your multi-layering technique?
Okay, in her case, and during to the assessment and her skin, she has a thin skin. So I don't want to use a stiff volumizer because I don't want to see or to feel any lumps on the skin. But in a fair skin and in a good, decent amount of tissues, for sure, I will use RHA, I will use ultra deep in the fat compartments and deep fat compartment because they are static. And this is a stiff volumizer. So I can use it deep on the fat compartments. Then I can use the RHA4 as a multi-layering agent, is a superficial volumizer on the superficial fat compartment, which will respect the dynamics of the face and respect also the movements and the 4D Tuxan approach.
Perfect.
I will use in the lower face, by the way, the ultra deep on the bone, and I will use the RHA4 as a multi-layering one.
Can we also ask one more question, Shadi?
Sure.
So you mentioned that the limit of your injections in the superficial region is your zygomatic line. Do you ever need to inject in the buccal area, a little bit lower underneath this line, for any situation where you need to have a smoother transition? Or do you always limit yourself to this line for safety reasons or any other reasons?
No, I don't want to increase the volume in the shaft fat pad or the buccal fat pad. So, and also here, after the E2E safety line, which extends from the mouth corner till the tragus of the ear, we don't want to inject here superficially. Even if I'm using cannula, I will increase the heaviness here, and it will contribute in more jowling. So, now I will start with the jawline. I would like to draw the patient first each time, so I will let her sit, please. Thank you. So I ask the patient to lean forward, and I will mark the jowling area I have, which mainly between 2 ligaments, which is the mandibular ligament, a true ligament from all the layers from the bone to the skin, and the premasseteric ligament. And this is a no-go area for me. And now I'm assessing the mandibular angle, I think she lost the definition a little bit, so we need to improve it with respect of gender differences. So in female, it has to be like 120 to 130 degrees. In male, it has to be 90 degrees or 100 because we need more square, stronger look. But in females, we have to respect the curvy look and the curvature of her face. Now we have here the pre-jowl sulcus, which lies here, just medial to the mandibular ligament, and we'll inject it. We have two ways to inject it, either deep or superficial. In her case, because she's young, I will prefer to inject it superficially, and also we will project and elongate the chin deep on the bone, targeting the deep medial cheek fat pad, and we will inject superficially in a multi-layering manner using RHA4. Thank you. Any
So
question,
just
Blue?
as we do with the mid cheeks, we can also do a multi-layering technique with the deep chin fat pad, the deep mental fat pad as well.
You know, Balur, what I like about the products we have in our hands and our tools, that we can use products just to improve the natural look and to improve the look we have naturally with respect of dynamics. So now I'm start injecting the mandibular angle. As we can see here, I'm using my index and my middle fingers to guard it. And I'm using my ultra deep using 27 because she has a thin skin over this area. And I'm going all the way deep till I touch the bone. Here's a safe area because the vessel or the main arterial supply here is the facial artery and it's in front of the masseter deep to the bone. So I'm away of it. I'm injecting it deep on the bone.
And how much are you injecting, Shadi?
In her case, I don't want to widen her gonial angle because she has a pretty good dimensions. So I'm injecting in total 0.2.
Okay.
As we said, I guarded the angle of the mandible because I don't want any lateral migration of my fillers. Now I'm using the ultra deep superficially, targeting the superficial fat compartment and the mandibular angle, because as we all know here, we have the skin, the platysma, the skin and the superficial fat compartment, as we said, or subcutaneous tissue. Then we have the platysma covering the parotid and the masseter, then the bone. So here we don't have a deep fat compartment. I will inject superficially to define the angle.
And which product did you say you were going to choose?
I will choose RHA4 because it's resilient fillers and it has a stretch and strength properties, and I can use it superficially with no worry. Now I'm using cannula, 50 millimeter, softer one, because I want to move and freely through.
How many gauge? What's the gauge of your cannula? How thick is the cannula?
It's 23 gauge cannula. As we see how superficial I am, I'm in the subcutaneous tissue, and I am guarding the posterior border of the ramus of the mandible, and I'm injecting just retrograde line, one more above it, one retrograde slow injection line, and I stop on my no-go area or the jowling area. I go, inject, and here, in females, I would like to go all the way up here till the tragus to improve it, and I'm not injecting ramus in female patient because I don't want sharp definition.
And are you keeping the opening of your cannula on the top on purpose, I assume, right? To make it superficial?
Yes, all my, when I'm using cannula, my bevel is always up. As we can see here, we can see some bumps. If I press it, it's totally forgivable. Then I'm using the same entry point, as we can see, and I go to reach the pre-jowl sulcus, injecting also superficially to avoid any danger here. I'm not advancing the cannula aggressively. I'm sliding the skin over it. Here, I'm in the subcutaneous tissue above the muscle, which is a deo here in this area. And I'm injecting to camouflage the jowling we have. Here we can see bumps. If I press, it goes all the way.
Yes, the beauty about the RHA series is that it's very forgivable. We do have some questions regarding the kind of products that we can use for the superficial injections, because of course, depending on the age, the ethnicity of the patient, sometimes the skin is very, very thin and delicate. And of course, you can use RHA3, RHA2 maybe sometimes. So it's actually a little bit about what you want to achieve as well for your patient. Depending on the quality of the skin, the thickness of the skin. Of course, sometimes we can do a multi-layering where we can use RHA3 on the superficial layers as well. So it's not set in stone. And as you've shown beautifully, depending on the patient, you can also pick a little bit of a more softer volumizer, such as RHA4 and the deep fat pads as well. So we have just a very, I would say, versatile expert toolbox at our hands where we can just tailor the treatment according to our patient's needs and desires. So it's very good.
Now I'm using RHA4 also to improve the marionette line. I'm using it very superficial. This is my entry point. As we see, I'm using RHA4 because I want to give support. You can see my level. I'm truly superficial. This is a very thin layered area. So here we have the muscle, and I'm here in the subdermal or the subcutaneous tissue. I can reach the mouth corner. I press and give a little bit, a small bolus and the retrograde line, not till the end because I don't want to induce heaviness in the prejowl sulcus. And I'm moving, injecting tiny droplet. The stretch properties here and the dynamic nature will improve and will give me a more natural look during dynamics, because this is a highly movable area. As we can see, immediate improvement of the mentolabial fold, and it's smiley now. Now we're injecting. Any question, Blue?
We can see the improvement right away, Shadi.
Perfect. So now I'm using Ultra Deep as a stiff volumizer, targeting the deep fat compartment on the chin. And here I'm using the 25G needle, 25 millimeter, just to improve it. If we can cut on the lateral one, please. Thank you so much. So what I do is bevel down, okay, and I want to elongate and project, so I will use the needle to project in gonion. I inject all the way deep to the bone, as we can see here. And I block all the vessels, and I'm injecting while bevel down very slowly. As you can see, I'm a very slow injector, and I'm watching the skin while I'm injecting. I have to rest on the bone. Bevel is in touch with the bone. I will not inject too much now. It's one.
How much are you aiming to inject in this deep mental fat pad?
Just 0.3 to improve the projection. And now I'm gonna use, I will use the RHA4 using cannula, 25G cannula. To inject it superficially, as we mark it here, this area. I will have my opening.
Are there specific landmarks that you use to determine which area you're going to inject when you are going to do it superficially in the chin?
I have to inject it superficially using the cannula. I have to avoid any danger here, and the dangers here are the ascending mental artery. So I'm using cannula, injecting very superficial, as we can see the tip of my cannula, and I'm targeting the mental now. I support with my hand. I'm injecting micro alkets. I keep moving.
And you are mainly staying in the borders of the nasal base, I'm seeing, right?
Exactly.
For a more feminine touch.
Exactly, because in gender differences, as we said, we have to respect it. So the female chin has to be as wide as the ala of the nose, and the male chin has to be as wide as the mouth corners to give us squarish look. Now I will massage it a little bit, just to mold the fillers. Can we have her sit, please? Zoom out.
Yes, we would like to see how she looks. Beautiful.
Thank you so much.
We
Can we
automatically see
zoom in here?
how this is just the mid face and the lower face has just improved immensely. You can see the clear cut of the lower face and the jawline in a very feminine way, in a very soft way. Same with the zygomatic area and the mid cheek. It's very beautiful, it's subtle, and it's just very respectful to her normal anatomical nature. So it looks beautiful. Could you just repeat how you choose your entry point for the marionette injections? Because we have a few questions regarding that.
Perfect. So when I choose my entry point for the jowling, I go from the no-go area. I will not inject here. I will inject anteriorly and posteriorly just to improve the area and to camouflage, as we have a hump here. So we need to make an eye illusion and have a more smoother straight line. In the marionette fold, I will choose my entry point from the pre-jowl sulcus, because as I injected superficially, I have the effect of lidocaine in this area. So I will go with my cannula, as I said, superficially, and I will do like a very superficial lines, retrograde injection, and I will give a little bit of bolus here to support the angle and give a more homogeneous look.
How much product did you give in the marionette shedding?
I just injected 0.3 because I don't want to inflate it, because we can see patients with this look because they want just to improve it, and they are going to inflate it irrespectively to the dynamics of this area. So the product is RHA4, which is a dynamic product, and we inject just tiny amount to support, because my concept is to do a network like this. So my network and the stretch properties we have is gonna support and improve the deepness here.
So the result is absolutely amazing. Could you just summarize what you injected, just to finish up what we did so everyone can follow?
Perfect. So I'm using in the mid face, I used RHA4 Brazilian dynamic fillers in the deep fat compartment, which is the medial SOOF, the lateral SOOF, the deep medial cheek fat pad. Then I'm used 0.6 total volume. Then I used 0.4 superficially in the superficial fat compartment, targeting the middle and medial and superior middle fat compartment. I didn't inject in the nasolabial fat compartment because I don't want to aggravate the heaviness here, or in the infraorbital. We will treat the tear trough for her and the palpepromalar groove afterwards. Then I injected using multi-layering technique also in the jawline. I injected the angle using 0.2 to 0.3 from ultra deep. Then I used ultra deep also in the chin deep 0.3. Then I chose my resilient dynamic fillers, injected superficially in the angle to improve the angulation and to camouflage the hump descent here or the jowls descent here. And I inject 0.3 in the pre-jowl sulcus. So in total, in the jawline superficially, we injected 0.7 in total, 0.3 and 0.4. And here I injected superficially 0.3 of RHA fillers. All my cannulas I used in the mid face are 25G cannulas, 38 millimeters. And in the jawline, I would prefer to use 23 or 22 gauge cannula, 50 millimeter flexible ones, because I want to draw the curvature of the jawline. And I used in the chin superficially to control my depth. I used the stiff cannula, 25G cannulas.
Beautiful. Thank you so much. I think that was an amazing live injection assessment and patience, and we've just learned so much from it. So now let's see what is actually going on underneath the skin. Patrick, can you hear me?
Yes, I hear you. Very zoom a little bit on the orbit. First, the superficial injection. You see that I use the same entrance point that Shadi, and I am in the superficial layer, as you can see here. If I move a little bit, you know, my superficial fat, you see here, you remember, it's my infraorbital fat compartment. Never Shadi injected here. because it's too thin. So I'm here in the medial fat compartment. And if I lift this superficial fat, and you see where is my cannula is, we zoom on it, you will see that my cannula is inside the superficial fat here. And I will do a small injection just for you to see where is my blue HA is going. So it's just superficially here in the superficial fat, as you can see here in blue, and it will be above the muscle. Then the second part of this injection will be deep in the deep layer. And so I push my cannula deep on the bone, and my cannula will be in the deep fat compartment. So if I remove this superficial fat from the mid cheek, you will see that my cannula is exactly here in the medial soup, and I will inject a small quantity, a small bolus of blue HA. You see here my medial soup. Then I move to the lateral soup, and at the end, I'm moving my cannula to the deep medial cheek fat compartment here, that is just at this location, and I will inject a bolus of blue HA. So you see, I realized a deep triangular injection in the 3 deep fat compartment. So this is for my mid cheek. And now I will go on profile to show you the deep injection in the just mandibular angle. If we go on profile, please, you will see that my injection here, I will use ultra deep as Shadi, and I will go deep with my needle here. And I put my 2 fingers here because it's, I don't want to be in the parotid. So here I will show you where is my needle. I lift here. Can we go on profile, please? And you see here that my needle will be here on the bone. You see my angle here. But if I'm going here, it will be in the parotid. So if we zoom a little bit on it, you will see that my injection will be deep. It's like the tear trough, this area, because there is no space between the muscle and the bone, because the muscle is attached to the bone. So my injection here will be beveled down and sliding a little bit on the bone, just to have all the product in a supraperiosteal plane and inside the bone origin of the masseter. Then I will use a cannula with RHA4, and I will be in the superficial layers. So it means that my cannula will enter in a superficial fat and will move superficially, as you can see here, in the superficial fat very with RHA4 again. And I will do a fan technique in the angle. So I will inject slowly. You see that my cannula is in the superficial layers here. And I will inject some bulk of product, just as Shadi did, with a fan technique in the mandibular angle. Then he moved with another entrance point. If we dezoom and we go face, and he was going from the jaw here. No, not here, in the lower part, here. And I'm going superficially here, just to do my marionette fold. So I will be very superficial, and I will go up to the mandibular angle that is just here. And I will inject a small bolus of product. So my cannula, if I move my, my superficial fat, will be in the superficial fat and will be in this fat here that is above, you see here the DAO, that is above the DAO. Last but not least, I will show you the injection of the chin. So we move to the chin just to show you the injection. So he did some deep injection. If we go to the chin here and we focus, if he was going with a needle in the deep fat. So my deep fat is a little bit, you see here. I will show you where is my injection of ultra deep. You see the blue of my ultra deep here. You see I'm in the deep fat. And then he use a cannula just to go, you know, through an entrance point here. I will do the entrance point. And I will introduce my cannula and show you where was the Shadi when he was doing his injection superficial. He was just under the skin, above here the muscle. And I will show you where is my cannula. My cannula will be here, just superficially. And I will inject small bolus of products. And I will show you where are these bolus here. Here I'm under the skin in the superficial fat compartment, just in the multi-layering technique. One is here, deep, and one injection is here, superficial. So to summarize, it was a multi-layering technique in the chin. If we move to the mid-cheek a little bit higher, you see here the deep fat is here and the superficial fat is here. So the multi-layering again. And if we go to the mandibular angle, you see where is my superficial injection here in the fat above the muscle of my RHA4, and my deep fat here, my deep injection here will be behind the muscle. If I open here at the posterior border, you will see that my injection was in this muscle that is very thick, that is the masseter muscle, and you can see the blue HA just here on the bone. So it was also a multi-layering technique, but because there is no deep fat here, it will be at the contact with the bone inside the muscular fibers of the masseter. So 3 areas of multi-layering injection, 2 areas with 2 layers of fat, with a dynamic product, and here in the mandibular angle, a multi-layering injection by Shadi with a deep volumizer, with a very high capacity of lifting effect, the ultra deep, and superficially RHA4 with a very good strength, a very good stretch, and very malleable product. I hope it was clear.
Oh, it was very clear, Patrick. Thank you so much. We do have a couple of questions, and I think we have a little bit of going back to the soup area. We have a few questions about the anatomy of the soup. Some of our viewers wanted to learn that when we are injecting the soup on the bone, are we actually in the soup or in the pre-zygomatic fats? And is there actually a fascia separating this fat from the soup? So they wanted to learn a little bit about the septum, I think, within the soup. And if you have a little bit of time to show us that, we would be very grateful.
Yeah, if we zoom on the cadaver, and if we are looking to this area where I'm injecting the product, if if I use my finger and I try, you know, with my finger to press on it very hardly, like I'm doing here, and you see what happens to my products here, if you zoom on it, you see that my product didn't move. It means that it's really a compartment. if you do a mistake regarding this anatomy, and you want with your strong massage here to push the product a little bit medially, as I'm doing here, the product never move. It means it's really a fat compartment. It's really a box where you put your product. So be very careful. Each time you target a fat compartment, be sure that you are in the right one. Because if you are not in the right one and you try to move this product, as you can see on this cadaver, and my massage is much more harder than the one you can do on your patient because I'm very close to the bone. You see that none of these 3 deep fat compartments move to another area first. So this is really a box. Then here, these deep fat compartments are behind. If we zoom on it, you see here the fibers of my orbicularis oculi muscle with 2 parts, pars palpebrae and pars orbital here, that is giving, you know, less and less fibers above these deep fat compartments. If I open with a blade the muscle, and I will show you what is under this muscle, you will see that these deep fat compartments stick to the bone. And because it sticks to the bone, can you take a pinch, please? You see here that this soothe here stick to the bone. So there is no here space between the fat that stick to the bone and the periosteum. So always in anatomy, we have to be very cautious, because when we do a dissection, like I'm doing here, you can create a plane and you think it's a real plane, but it's not. So here you see my product in the soothe. You see here a tiny branches going up that is coming from the bone. And you see here, if I open here the periosteum, you see that my fat here stick on the bone. I need my blade to lift this area that some people call the premaxillary space. But here, you don't have any layers that could allow, you know, the products to be in compartments or in a layer that could not move. So it's really a place where the fat will not move, will remain on the bone. I hope it was clear.
Yes, absolutely, very clear. So there really is no space where we can actually, it's called a space, but there really is no specific space where we can actually have the product move.
Exactly. For us, we did such a lot of dissection in this area, try to find the right way, as Shadi showed you, the different fat compartments. Look here, my last point. If I draw lines like Shadi did, first line, I will draw a line that is a vertical line of the face here. So this line is a vertical line. Here, medially, you have the medial soothe. Laterally, you have the lateral soothe. The other line will be the mid-cheek groove here. So this is my second line. And this line is very important because this line is the lower part of the medial soothe. So Shadi, when he put his cannula, he was just here in the medial soothe. He withdrew, he was in the lateral soothe, and he went there to be in the deep medial cheek fat. So remember, you don't need an anatomical book near to your patients. You just need to draw these 3 lines. Thank you.
Absolutely. Landmarks are very, very important for us. And finally, I think we have room for one more anatomical question because we have a very interactive audience today. So I want to get in as many questions as possible. We have a group of very fascinated by the zygomatic area and the danger zones with the transverse facial artery. Could you please, for those who were not able to really see it clearly, show us the transverse facial artery and the danger zones in that area under the zygoma?
The transverse facial artery is just here, as you can see here. she's really, can we just zoom on this area? We zoom here. You see, this is this tiny branch here. I don't know if you see it very well.
Yeah, it's absolutely visible.
And you see here, the white here, that is just below, this is the facial nerve that we don't want to encounter when we do a facelift. So this is a facial nerve. And just above, you see here, the tiny branch up here, that is the transverse facial artery. And this branch is always below the zygoma. My zygoma is just here. You see, I palpate my zygoma here, and my transverse facial artery is just here. Always there. Remember, it's always there. And then this artery is going, you see, inside here, these ligaments that we call the ligaments that is in this area is the first ligament described, you know, it's the upper part of the pre-masseteric and buccomandibular ligaments. And you see inside these ligaments, if you look very well, you see a tiny branch. So this here artery that you can see here is going in these ligaments as always in your face to go perforate the superficial layers to become, you know, a plexus, as you can see here, on your skin and create the vascularization of this area. So this is the transverse facial artery here, the transverse nerves, and here, you see what is that? This is the stenon, the parotid duct that is always with these three elements, transverse facial artery, facial nerve, and parotid duct. And all these branch here, the parotid duct is going after here in the Bichat fat pad. Is it clear? It's
very, very clear and just very well detailed explained. Thank you so much, Patrick. I think we can maybe go back to Shadi and we can take a look at the final results of our patients and then maybe move on to patient number 2. So Shadi.
The palpepromalar groove just to smoothen out the curve between the lid cheek junction. So I injected in total 0.3 of Pradenis 2, which is specific for this area. And I injected in the middle tear trough, and I don't go anywhere deep because here we have a lot of veins, superficial. So, and I want to accentuate the infraorbital fats here. So I injected to smoothen out the palpepromalar deep on the bone under the orbicularis oculi muscle and smoothen out the anterior projection. If we can see, in her case, we didn't inject laterally to lateralize on the zygomatic arch. We inject anteriorly to improve the vector in her case, because we know there is a vector extending from the most prominent part of the cornea and resting on the anterior cheek. This vector can be negative and gives us a tired look and deflated look. It can be neutral, which is acceptable in males, but not in females. And in females, we need a positive vector to give us more healthier, rejuvenated look. And that's what we achieved. So if we can zoom in on the jawline, please.
The result is fantastic, Shadi. I mean, beautiful results.
Thank you. Here we can see the curvature of the jawline. It's we respected the curvy look of the female. There is no more drooping here or jowls. It's almost a straight line, and the integration will happen after 3 weeks, and we'll see sharp chiseled look, but naturally. Here we improved the pre-jowl sulcus, and we blended the jawline with the chin. We improved the projection, as well as we elongate the chin a little bit. If you can check, here is a Ricketts line, which is a line extending from the most prominent part of the nose, the soft tissue of the nose. We can see, can we go a little bit like this, please? Can you open the lateral one? if we can check here, it's extending from the tip of the nose till the apex of the chin, and the lips are way, upper and lower lip are way behind the line. So we can see we achieved that. And if we take an anterior view to see the difference, or if we widen the gonial angle or not, can we come a little bit like this? It's not widened, it just is smoothened out and improved. And we treated the marionette line just to support and raise the angle of the mouth.
It's all very visible, Shadi. All of the little areas that you focused on and the results that reflect on the face. It's very beautiful, very harmonious and balanced. I think it's perfect. I'm just looking to see if we have any other questions. There are, of course, questions regarding the differences between the products. So they would like to know the difference between RHA3 and RHA4 and how you decide which product to use, for example, for the superficial plane. This has been asked quite a lot. So maybe you can clarify this for us.
Perfect. So we have the RHA range, which is RHA1, semi-cross-linked and cross-linked, and we have RH2, which is a high stretchable product, which is my product of choice in lips, as we will show in the next live demo. And RHA3 and RHA4, and they have also strength and stretch properties, but more of a strength. How I choose both, I choose RHA3 or RHA4 injection superficially, which both can be used, but I check it according to the skin thickness. If I have good fair skin quality, I will use RHA4. If it's thin a little bit, I will use RHA3. And I prefer RHA3 if I will inject nasolabial folds superficially to support, but not in all cases, because I don't want to accentuate or have migration of the fillers upwards in the superficial nasolabial fat compartment. So I will inject very superficial, as we say, subdermal RHA4, RHA3.
Beautiful. So how many syringes in total did we use for this patient, Shadi?
Okay, we used 1 ml of RHA, 1.2 ml, so it's 1 syringe of RHA4 and almost 1 syringe of ultra deep and half syringe of almost half syringe, because it's 0.4 of Brad 2. So in total, it's 2.5. It's less. It's 2 ml of volume because it's half syringe of ultra deep. I inject here 0.3 and here 0.3 also, so it's 0.6, and here 1.2 ml of RHA4 and 0.4. So in total, we are talking about 2.2 ml.
That's very good. Very, very impressive.
And this is the message we want to say. We don't have to use large amounts to achieve results, and we have to achieve the aesthetic desires of the patient himself. If he asks for rejuvenated, healthier look, so we inject according to anatomical knowledge, which is extremely important, the right product in the right layer, so we will achieve the outstanding natural dynamic results.
Can we also see our patient smile? If
Yes.
That's okay.
Can you smile, please, Julia?
Beautiful.
Zoom in.
Right. I think that smile can be a good conclusion to patient number 1. And Shadi, if you are ready, we can just directly stay with you and we can continue with your second patient. You can see how beautiful the smile looks and how the products in the superficial fat pads just accentuate her beauty, but don't create any lumps or bumps or any kind of irregularities. So very well done, my friend. Beautiful results.
Thank you, Bilal.
Would you like to continue with your second patient, or
I can inject Julia also, because we agreed on injecting the lips because we need a variety of treatments. Okay, so I will inject. She has a beautiful lips, but she needs more rejuvenated. We can see a little bit of asymmetry in this between the left and right lip. We can see the JK point is a way higher. So we will inject the lower and upper lip just to beautify it, not to augment it or not to project it. Just we need to define, beautify using high stretchable product like the RHA2, which is my product of choice in her case. Okay.
Okay. Yes, we're with you. We're watching you.
Thank you. So if I want to recap the anatomy of the lips just in hurry, I will. Can we zoom in, please? Here. As we said, we have the facial artery, and it goes in a tortuous pathway. It gives us the inferior label deep to the DAO, and it pierces the lips from the lateral 1/3, and it goes deep in the muscle. Usually, we have the artery in the wet-dry border. I will show it during injection, and then it gives us the superior labial artery, which enters from the lateral, and here we have the columella and faltral branches. So this is our main danger in this area, which is the superior and inferior labial artery, and it lies deep in the mucosa or intramuscular. Only 2% it can lie superficially. Lateral, please. So, zoom in, please. Here we have the white lip. Here we have the white lip and the red lip, the cutaneous part and the red lip. And in the red lip, we have the dry lip and the wet lip. In between, there is a wet-dry border. Here is where the artery goes on its pathway, maybe 2 millimeters inferiorly, 2 millimeters anteriorly, or 2 millimeters posteriorly. So what I do is I like to palpate with my fingertips where the location of the artery, because in the face we have 3 main areas that we can palpate. We can palpate the facial artery in the notch in front of the masseter, we can palpate the superficial temporal, and we can palpate the lip. So when I feel now it's deep in the mucosa. So what I will do, I will use RHA2, 30 gauge, 13 millimeter needle, bevel up, and I am superficial. I'm injecting superficially above the muscle. I will enter from the JK point as we see. Lateral, please, lateral camera. And this is my level of injection. And I give a retrograde line. I stop just before the wet-dry border and all the way up. And I leave a tiny droplet. So I do a fencing technique using minimal product for the lips beautification. If I have an old age patient, I will use RHA2 also to restore the volume, not just rejuvenate. And I can use RHA3 in millennials if they need volume, large volume lips, but with respect of the anatomy. As we see, I'm too slow and gentle. I stop at the ale of the nose. So my boundary, I will not go laterally because I don't want to widen the lips. So what I do, I stop here, then I want to improve the angle or the mouth corners. So what I will do, I will use my non-dominant hand, I will support, and I will go very superficial in the vermilion border, and I will inject tiny droplet. I can see it goes all the way here to improve it.
So
So
you've
now
done
we can
a vermilion injection in the virtual canal to improve the border of the lip in the lateral portion only, without any
exactly. So yes, we did the borders, and we do like fences, all the fences here, just to improve and to support and to avert the lip. Naturally, no flat look, no over projection, and this is what we target. Can we sit? Zoom in, please.
Can we have a frontal view from the patients? Okay, beautiful.
Yes.
Yes.
Yeah. We can see the
Okay.
difference.
Absolutely,
Here.
we can see the difference.
Subtle, plump, and at the same time, it's defined. Now I'll continue with the lower lip.
Could you use this? Could you do this technique with a cannula as well? Would you ever prefer to use the cannula for the lips in any
Yes.
situation?
You know, I used to love cannula for injection for lips because less side effects. But at the same time, when we inject using cannula, it's more traumatic in that sensitive tissue. So I'm using it only in thin patients that I want, thin lips patients that I want to add volume in respect of anatomy. So I'm using cannula, very superficial because the level is the same with any tool we have, even if it's cannula or needle.
Absolutely.
And my entry point will be laterally. As we can see, there is an immediate improvement of the vermilion border. Goes, please. Goes.
And we can see that with your gentle technique, there's not even hardly ever any bleeding at all.
Yes, as you see,
that's actually, that can actually be prone to bleeding.
Yes, please being slowly, being gentle, and there's no a tiny drop of blood. Now we inject the lower lips. I will let the patient sit to see the difference, but I will inject the cupid bow. My injection technique for the cupid bow is extremely superficial, as I see, and I do the push-pull technique. I pushed, now I will use the other side while injecting just tiny line and pull to define the cupid bow.
Mm-hmm.
Can we sit, please?
It's lovely. It's
Zoom
a very
in here,
beautiful
please.
result, Shadi.
Yes. And still subtle and improved the aversion and with respect of the Ricketts E-line.
Absolutely. We can tell just how subtle and how natural it is, but it's a great case of beautification without going over the limits and creating anything unnatural. So very beautifully executed.
And that's what I love about the RHA2, that I can use a tiny amount. By the way, the total amount I used is, can we zoom in here, please? The total amount I used is 0.2. So per side 0.2, so in total for lips 0.4.
Beautiful.
Thank you.
So if you don't have any other areas to inject on our patient, this patient, would you like us to go over to Patrick to look at the lips? Is that okay with you?
Yes, perfect. While preparing my other patient.
All right, perfect. Thank you so much. So Patrick, can you hear me?
Yes, I hear you very well. So back to Paris. So if we are looking to these lips, I will just show you where was Shadi with this Cupid's bow injection and the vermilion border. So he was injecting a little bit in the mucosa, in the virtual canal, and will inject the product. As you can see, the blue is going in the virtual canal, as you see here, and will be very superficial. So you see my blue is injecting inside this virtual canal. If I open this virtual canal, I will turn a little bit like this and look where is my products. I will just open it and you will see that my product is really in a place. If we can zoom on it, you see that my product is just in the virtual canal, really very, very close to the mucosa, as you can see, like a little tube of product. So don't push too fast. And you see that my product is just between these two areas here. This is a weak point. There is no virtual canal, but there is a weak point, and you see that the products remain in this canal here. When he was doing the superficial injection, the vertical, injection, we will dezoom a little bit, go on the other side, and I will show you where he was. So in that case, he was going, under the mucosa here, vertically, very superficial, as you can see, and he was injecting some little drops of products in the red lip. Don't forget not to inject only the Cupid's bow, the vermilion border, because if you forget here the mucosa, it will make like a duck lip. And I will show you where is the danger. If I take, you know, another pinch here, and I lift a little bit here my fat, you see here the orbicularis oris muscle. But if we zoom a little bit on this orbicularis oris muscle, you see that my artery here is crossing the muscle, as you can see here, will cross the muscle to be under the mucosa. So here I lift this muscle, you see my artery here, and this artery that is very big, as you can see, is far away from the shady injection that was here. Where is my needle? Here. So my needle was above, you know, this artery. And this artery here is at the junction between the red dry and the red wet lip here. So this artery is very big and it's a big danger because look, I'm entering inside here. So here I will create a HA embolism if I'm here deep in the muscle. So be very careful. If you are here in the upper lip, the arteria labialis superioris is a real danger. And look, where is this artery here? That is an artery, that is the sublobular artery that is going here. And the last one in this area will be a little bit more medial here. You see this artery here. Very well, here. That is in the philtrum column, as you can see here. A big one also. So you see 3 arteries in this area. Superficial, if I can draw a line, the lateral third, your artery will be superficial on here of your lips. Then 1/3, 2/3, your artery will be submucosal. And then it going here in the philtrum column, you know, will give, you know, a superficial branch. So be very careful when you inject the philtral crest. And if you are going to the lower lip, if we go a little bit downwards here, if I move, you know, my fat away from this area, you see that it's totally different. It's totally different because this artery here is deep and will send branches up to the submucosal area. So I pull on my mucosa, and you see that this branch here was giving, you know, a branch that was going under the mucosa. So it's just here. I don't know if you see it very well on the screen, Bilur, but it's really
it's very visible. Yes, yes, we can see
submucosal artery. Yes, very good. The zoom is very good here. So it's big trunks. So be very careful when you do injection or when you want to test new technique in this area. You have to keep in mind that all these arteries are big. And if you are with a needle, be very cautious when you are going here in the first lateral third here in a subcutaneous layer. So here is the dangerous area with an artery that is just here, as you can see in my pinch. Then it crosses the muscle and will be here in a submucosal area. So I open the muscle and my artery is just here. So this is a big trunk. Be very careful, and be careful also in the philtral crest to be very superficial, because this is the last artery of this area. I hope it was clear for all this injection.
It was very clear, and it was such an amazing wrap up of all of the areas that we have to be very cautious about when we were injecting the lips. So thank you, Patrick. It was very detailed. And I think Shadi is ready for the second patient. Of course, time flies when we are having so much fun and obviously having great time learning, but we are a little bit short on time, Shadi, so I'm going to ask you to limit it to about 10 minutes, if that's okay with you.
Perfect. So my friend Yomna, she just asked for a slimmer face, as we can see. So my approach will be injecting in the mid cheek. I will do a little bit of anterior projection because in the nasojugal groove here, we needed the zoom in, please. We have like indentation, so we need to improve the anterior projection of the cheeks. We don't want to lateralize the face. And I will inject the chin to elongate it and to project it so it will give us more slimmer look. So if we have the assessment quickly, we have the rule of thirds. So the middle third and the upper third and the lower third. The upper third, I cannot control it because of the hairline. So if we can check here the dimensions, we can see the relation, it's not the same. So we need to elongate the chin a little bit to improve the dimensions. So what I will do in her case, I will inject deep, ultra deep, because her skin quality is so good. So I can inject 3 boluses of ultra deep, deep on the bone. In the deep fat compartment, in the static fat compartment. Then I will inject superficially using RHA4, or maybe I will just use the ultra deep to project and to support.
So depending on the case, sometimes you can do only maybe a deep injection.
Exactly.
All right. Would there ever be a case where you would only do a superficial injection? Do you think that provides anything?
Yes, if I want just to smooth the curvature and to improve the lights and shadows, I can use ultra deep. I can use, RHA4 superficially alone. And as we said in the last case, if I inject RHA4, I can use it deep and superficial. Zoom, please. Thank you. So now I am with cannula using ultra deep. I prefer to have the bevel down using ultra deep or RHA4 deep on the bone. I raise my cannula. I cannot feel anything. I'm using 25G cannula, but this time it's 50 millimeters.
A little longer than last time.
Exactly. And I'm injecting as I'm moving, I'm moving continuously. I'm injecting tiny aliquots, tiny droplets, and my non-dominant hand, I can feel the tip of the needle to avoid any wrong injection in undesired place. Here I'm injecting the medial soup as we discussed earlier in the past case. And now I injected in total 0.15. I will continue to 0.2. And this is my main target for injection in her case. As I said, there is indentation in the mid-cheek groove. So I will concentrate on the medial soup, which is the most recipient fat compartment for volume. And I will go a little bit down, raise up, use my non-dominant finger to guard. I can feel the tip of my needle. I am deep on the bone, and I'm injecting while moving the DMC. I want to enhance her anterior projection. Then I'm out easily. Then I can use, I will inject a little bit lateral to blend the cheeks with the zygomatic arch. I will use the same entry point. I will go deep on the bone as we see it. Then I move my direction deep on the bone. Here, zoom in, please. Yes. Then I guard laterally and I inject just tiny lines to improve the zygomatic arch, and I'm out. In total, I injected 0.7 of product, 0.6 in the anterior cheeks. Can we sit? Zoom in,
from the
please.
front, please. Can we see from the front?
Yes, zoom in.
Okay, yes.
We can see the improvement of the anterior projection and the shadow here naturally. And here we can see the deflation we have in the mid-cheek groove and less
Very
anterior
visible.
projection. We can see the light reflection on this side. Now I will do the chin in a multi-layering technique, but I will intend to elongate it more. Thank you. So I'm using. Do you have any question, Bilur?
No, it's very clear. And thank you for explaining why you decided to do a bit more of a lateral injection for this patient. So for the previous patient, we were focused mainly on the medial area of the cheek, but for this lovely patient, you did a little bit of a lateral injection as well to harmonize the face and make the shadow continuous in her zygoma. So very beautifully done.
So I will inject using ultra deep on the bone while guarding and blocking the artery. I'm all the way on the bone and my bevel is down and touching the bone. I'm injecting all the way.
Do you use any different points of injection if you are trying to create a more anterior projection or to elongate the chin?
Yes, I'm using the ultra deep on the bone in the meibomian if I want anterior projection in the mental, and I change the direction of my needle on the bone as I will do now, just to improve the length of the needle. I'm resting on the bone and I'm injecting too slowly. I keep moving while injecting. So I'm not injecting deep boluses, I'm just injecting microallocates beside each other. Now we can see there is improvement in the projection. For elongation, I will use RHA4 superficially, but in another direction because the direction of my cannula will influence the movement. It will influence the length of the chin. So what I will do now, I will have my entry point here. Can you take a breath, please? And that's it. Just tiny prick. And I'm using RHA4 in a multi-layering technique superficially in the superficial fat compartment. So we targeted the deep mental fat, which is the only deep fat compartment in the lower face. Now I am moving superficially. We can see the tip of my cannula.
Yes, we can see very well.
And I'm injecting in the midline slowly and lateral to it, and I'm keep moving, as we can see here. What's our anatomical danger here? It's the superficially, the ascending mental artery, which is in the subcutaneous or muscular plane, lateral to the midline, almost by 6 millimeters. And deep here, we have the mental foramina and the mental neurovascular bundle.
We have so many questions coming in. Of course, it's not easy to answer every single one of them, but in general, I think we are going over all of them. So they wanted to ask if we can use ultra deep in the chin with a retrograde technique. So of course, because ultra deep is on the bone, it's going to stay on the bone. So it's not really a retrograde technique, right? When you said movement, you mean micro movements, I think, right? When you are doing the injection.
Yes, it's not a pyramidal movement, because if I inject all the way out, I will go for all the layers. So the risk of occlusion or the risk of have a vascular incidence will be higher. So I'm injecting deep under the mentalis muscle on the deep mental fat. I'm injecting on the bone, but I'm moving my tip just to not to give a big bolus at time. And I'm moving, give microallocates, microboluses just in the same area. Of total, I gave here 0.3. And multi-layering, I used RHA4 superficially. As I said, I move continuously to improve this area, and I can give a soft contour, not just a sharp wedge chin.
Absolutely, absolutely. And again, you were in the limits of the female ideals, which were actually between the nasal base. So again, very beautifully done. So for a male patient, would you pick your areas differently in the
Exactly.
chin?
Exactly. Because can zoom in, please. In male patients, I will choose my area just as wide as the mouth corners. And in female patient, I will choose my limit of injection will be as wide as the ala of the nose. I want the most projection here because, as we know, the feminine features are tapered, rounded chin, and for the male, it's a squarish, chiseled chin. We have to respect the gender, the age, the ethnicity, and the aesthetic desires and need. Thank you so much, Blue. Can we sit?
That is a beautiful result. We can see from this oblique view just how the balance between the thirds of the face have just gotten so much better.
Zoom in, please. Zoom out. Zoom out. Zoom out
Very
a
beautiful.
little bit, just a little bit, just a little bit. Yes, thank you. And here we can see. Now
Can we
we have more elongated chin, in balance to the middle 1/3, which has a projection and light shadow in the anterior cheeks and subtle enhancement of the lateral zygomatic arch.
That's beautiful. We can see the difference very, very clearly. Can we also ask her to smile? All
Can you
right.
smile, please? Ms. Nanik? Thank you.
Very nice.
Yes,
Very
we
nice.
preserve the movement and the natural dynamics of the face. That's why we are targeting we have here the multi-layering approach and the 4D approach, that we have to respect dynamics. We inject deep and superficial using the right product. So while she's smiling, I cannot see lumps, I cannot see the cheeks, close her eyes, or giving unnatural, unwanted anterior cheeks.
Absolutely, absolutely. Thank you so much, Shadi.
Thank you,
Amazing
Blue.
injection.
Thank you.
And over to Dr. Patrick, so we can maybe just summarize these two areas again, and maybe go over some more technical details with the amount of time we have. We have about 6-7 minutes left. Patrick?
It's okay. It's okay. We are going just to the chin first. So we are going downwards to the chin. And then you will see that I did what Shadi did on my cadaver with 2 layers. If we can go on profile, perhaps it will be better. Yes, so here you see the 2 layers I injected. In blue, the superficial layers. Here, if we zoom on the chin, you see really well the 2 layers. We can go down a little bit, zoom a little bit more. I'm here in the deep fat with ultra deep, and here is my RHA4 in a superficial way. As you can see very well, you see the mentalis that is just here in pink. You see it very well here. That is the limit between the deep fat and the superficial fat here. Same if we go on the cheek now. Okay, we go up, same way. You see here, stop, very good, very, very good. Here you see the deep fat with the deep, injection that did Shadi on the bone. So with the 3 target, medial SUF, lateral SUF, and deep medial cheek fat. And here, you see here in a superficial way, here, close up, here. This is my superficial fat injection. I did, in the superficial fat here. So multi-layering technique, exactly the same anatomy, bone, deep fat, non-mobile, muscle and superficial fat that is mobile, and same for the chin, same for the mid cheek. So 2 similar areas for injection. Thank
Absolutely.
you.
Patrick, could you also please show us the area of the zygomatic cutaneous ligament? We have some very I would say, hardworking anatomical studying colleagues here that want to look at
Yes.
all the details. So
there is a recent publication on the zygomatic ligaments, but it's not the first time. So if we are looking to the zygomatic ligaments, it's a very strong structures that take, place first in the medial part from the inferior, foramen here of the infraorbital pedicles here. So this ligaments is going, if I'm going with my blue HA, is going like this around. So if we go face, it will be better to see it.
mm-hmm.
And these ligaments here finish. You see where is my zygomaticus major origin here? If we zoom a little bit on it, you see these ligaments is very strong and create a border that doesn't allow the liquid to go down. It means if you are like my needle, the liquids are going here and stop at this level, where is the zygomatic ligament. This will create the malar mons and all the malar edema, or even in a post-surgical, eyelid surgery, all the bleeding, all the bruising will stop at this area because it's a real ligaments. We make a difference in anatomy between real ligaments and the septum. It's totally different. Let me show you the difference. Here, you see here, it's a septum here. You see here? It's a septum here. This is a really strong ligament that is going from the bone to the skin. And these ligaments doesn't allow the liquid to go down. So if you have here some issue with your genetic, with your lymphatic path, you will create a swelling in this area. This is for me a big contraindication of any injection, moreover in the superficial layers.
Mm-hmm.
It's clear?
Very clear, very clear. And finally, we have a question about how we can inject the area in front of the masseter when we want to enhance this area. But is there ever a risk of injecting the parotid? So can we see the relationship?
Yes, we are going to look, in the mandibular angle here. So we are going on profile, and I will show you. So first, what is very important is to understand that the parotid here, that is this gland, is mobile. It means the position of the parotid is totally different if you are in a sitting position or in a lying position. In a lying position, the parotid will be, here behind the mandibular border. My mandibular border is just here. And this is my parotid here. So if we zoom a little bit with our camera here, and you are looking, this is my posterior border of my mandibule, and this is my parotid here. But this parotid here, when you are, standing up, covered a little bit the posterior border of the mandibule and cover also the mandibular angle. And moreover, there is a part of the parotid that follow a little bit the parotid duct here and will be the anterior part of the parotid that is going up with the parotid duct here to the buccal fat pad that is just here. So if you are in a standing position and you are a little bit too superficial, you will be here in the parotid. But if you are, in a lying position and you want to reach the mandibular angle, but you don't touch the bone and you are a little bit too posterior, you will be in the parotid. So yes, there is a risk to inject in the parotid, and unfortunately in the parotid you have the parotid ducts, and the parotid ducts communicating with your interior mouth ear. So there is bacteria inside, and so we can see some infection if you inject in the parotid with hyaluronic acid. It was clear?
Very clear, very, very clear indeed. I think we are, I mean, of course, there are many questions, but it's not easy to answer all of them. I think we covered a very high ground in such a limited time. So I would like to start by thanking Dr. Shadi, my friend. He did an amazing job with injecting 2 patients, and he did a very tremendous result with both of them and showed different techniques. And of course, we'd like to thank our mentor, Dr. Patrick, for giving us one of the best anatomical lessons and lectures that we've had in a long time. So thank you very much.
Thank you. I want to thank also all my team around me with Sasha, that is near me, and also Gisela, who did this dissection for us.
Oh,
thank
it was
you
a
very much
beautiful
to them.
dissection. We'd like to thank Teok-san for allowing us to have such a beautiful presentation and virtual session in order to connect with all of you today. And it was my true honor to be moderating you. So I would like to thank you for being here. Thank you, Shadi. Thank you, Patrick. Thank you, everyone at Teok-san. And I hope you all have a lovely day.
Thank you, Bilur, for being our host. Thank you, Patrick, for the amazing, tremendous efforts and knowledge we had today. Thank you so much.